The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting the podcast, and thanks to everyone for listening in. So this week, we are going to do a deep dive into site-neutral payment policies. I've mentioned site-neutral payment on a number of other podcasts as part of a larger topic here. For example, when I talked about price transparency in a few blogs and a podcast, I mentioned site-neutral payments and how they're a bit linked. I also mentioned site-neutral payments in my proposal for healthcare reform and in my deep dive on price reform, one of the three tenets of my healthcare reform proposal. But I have gotten some LinkedIn messaging as well as some messages to the Healthcare Labyrinth website and comments. And people wanted to hear a little more on site-neutral payment policies, really sort of a deep dive, why it's important, what are the costs, and how it impacts both the system as well as, more importantly, the out-of-pocket costs that everyday Americans pay. So we decided we would tackle that one today. We're going to take two breaks here. This might be a relatively short podcast for me, but you never quite know because I'm just starting it now. But before the first break, we're going to talk about what are site-neutral payment policies and what's the impact on the system generally and everyday Americans in terms of outpatient costs. After that first break, we'll go into the history of site-neutral payment policies. So we do have some laws in effect, but as you'll hear in a minute, we're sort of in limbo right now. There hasn't been made a lot of progress, both on the Medicare and the commercial front. We'll go into the current cost to the system, as well as the potential savings in Medicare. After the second break, we'll get into commercial. There's a movement in commercial for site-neutral payments, but there is a bit of a stall because of the lack of action in Medicare. We'll talk a little bit about how the two are connected. And then we will conclude with talking about what the hospital's views on this. These are the main opponents of site-neutral payments. As many of you know, I am a former board member of two hospitals, one a children's hospitals and one an academic health center. So I understand what hospitals go through. But I will tell you, as much as I'm going to lay out their opposition, I'm also going to immediately poke holes in that opposition because I feel like the hospital's opposition is false and it actually keeps them from reform and it's hurting the overall system, especially the costs in the system. So that's sort of the roadmap for what we're going to do today. And let's get right to it here. So as I mentioned, site-neutral payment policies are a bit in limbo right now. We do have some infrastructure about site-neutral payments that we'll talk about a little later, but it's a bit stalled. But there was some great hope at the end of last year, December 2023, that we could start to make progress again on site-neutral payments. So late last year, the House of Representatives passed what I view as a very small step towards site-neutral payment policies in Medicare. We'll tell you a little more about that later. But the Senate did not pass the bill due to opposition from, you guessed it, the hospital industry. Since then, however, in 2024, healthcare advocate groups and others have made a full court press to pass something in 2024 because of the real impact on everyday Americans not having site-neutral payment policies. The hospital lobby, again, is strong and has resisted these types of reforms for years. I will tell you, I will give the hospital lobby and to some degree the provider lobby, the AMA, great credit for being a stellar lobbying organization. I say that a bit positively and negatively. I feel like the role of special interests in Washington as a whole, but on health policy is very negative because it really stops us from reform. But as someone that has been in government for years and understands lobbying and the interactions of corporations on Capitol Hill and state legislatures, I also rather admire how good they are at what they do. They have a great hold over lawmakers in both parties, and so they have been able to stop reforms. So from that standpoint, you have to admire them. But again, I think it's terribly negative to the system as a whole. But there is some evidence that the hospital lobby is starting to lose steam, at least on site neutral payment policies. Various healthcare advocates, health plans, and again, other parties have made the case that site neutral payment reform and policies are critical to lowering overall costs in the system, as well as rising out of pocket costs for everyday Americans. We'll go deeper into that in a little while. And of course, I believe they are right. And that is why I have made site neutral payment one of the key reforms within my healthcare reform tenets, the tenet of price reform. So with that quick opening, let's talk a little bit about what are site neutral payment policies proper. Well, we're going to go to our place of service code listing right now. And we're going to tell you about certain place of service codes. And this is how various providers bill insurers, as an example, or the Medicare fee-for-service system. They say, this is where I, the provider, performed the place of service. Now, that provider could be a hospital, it could be an ambulatory surgery center, it could be a physician, but on that claim to either a private insurer or Medicare fee-for-service, they will basically say this is where the place of service that the procedure or diagnostic test or other surgery, even as an example, was done. So let's talk about and give you a background on those place of service codes first. So there's dozens of place of service codes. I'm only going to talk about 6 of them here, just to sort of orient ourselves to what site neutral payment policies are. Well, first, place of service code 11 is physician office, and that place of service code would be used by a provider to bill for primary care visits all the way up to specialist diagnostic treatments and procedures and things like that that can be done in the physician office. Place of service 19 is what is known as a off-campus hospital outpatient department. And we're going to get a little deeper into that. But think of the fact that hospitals have campuses and they often have outpatient surgery and other services right on that main campus where inpatient is housed. But increasingly, hospitals are also buying off-campus separate facilities where they perform various services, and that's place of service code 19. There is place of service code 21, which is inpatient hospital treatment. There's place of service code 22, which is on-campus outpatient services, which we just talked about in relation to place of service 19. Place of service 23 is the emergency room at a hospital. And place of service 24 are what are known as ambulatory surgery settings. And these are these freestanding off-campus settings as well. And these ASCs sort of equate to place of service 19 off-campus hospital outpatient because they're freestanding. But again, the difference is in the case of 19, a hospital or that kind of entity owns that freestanding facility, whereas in 24, that freestanding facility is independent. So let's go back to place of service 21, inpatient hospital, and place of service 23, emergency room. We're now going to take those codes and places of services off the table. These are sort of unique places of service that I think everyone agrees needs to have their own rates and processes for billing. So inpatient is unique. Let's take it off the table. ER, again, rather unique. Let's take it off the table. So they are not part of the site-neutral payment policy discussion. But these other places of service 11, physician office, 19, hospital-owned off-campus outpatient, 22, outpatient on-campus hospital-owned, and 24, ambulatory surgery freestanding centers are in this. Now, I would note that I'm making it rather simple here, limiting it to these 4 places service codes. There are other codes that can be involved in site neutral payments too, but these are sort of the key ones. So the point is that these 4 codes, 11, 19, 22, and 24, increasingly are being done similar services. They could be just general visits all the way up to rather complex surgery these days, diagnostic testing and procedures in the middle. So the same types of services in roughly comparable types of settings are done in these 4 places of service. And today in the Medicare reimbursement, and I'm going to also say in the commercial world, payment rates vary dramatically between these sites. And place of service 11 and 24, physician office and ambulatory surgery center, tend to have lower payment rates than place of service 19 and 22, the places of service owned by hospitals. And that's because of various historical treatment of rates for hospitals, as well as what's known as a facility fee. And we're going to get into that in a little more later. But generally speaking, 11 and 24 are reimbursed at much lower rates, and 22 and 19 are reimbursed at higher rates. Well, with that introduction to place of service codes here, site neutral payments, quite simply, is paying the same amount for the same service regardless of the place of service or location. So site neutral payments would basically say for a given like service or diagnostic test or procedure, basically place of service 11, 19, 22, and 24 would all be paid the same rate, and that would be mandated first in Medicare, and then we'll talk a little more about how commercial would be helped by that as well. So again, just to underscore, traditionally outpatient hospital settings, whether 19 or 22, have gotten paid far more for the same service that could be provided in other ambulatory places of service. Hospitals are simply paid higher rates, historically in the rate setting system, or they add, again, these so-called facility fees to the charges for the service. This can occur with simple labs and x-rays again, or complex radiology, or even same-day surgery. So all of that differential for place of service 19 and 22 would be eliminated, and all of these like services would be paid the same rate in Medicare across all those places of services. So let's talk a little bit about all the confusion that the lack of site-neutral payments causes. Well, first, having worked at health plans and being associated with providers and followed this all my life, I can guarantee you that health plans, providers, and people don't quite know what's going to happen when they go get a surgery or a test or a procedure at a given place of service, and what's going to be billed and what you're going to pay. Health plan departments do not have the technology or even sometimes the knowledge. The provider relations department, the care management department, the claims department, and even the call center just does not have the knowledge or information to tell a member or patient the correct cost sharing. Number two, providers certainly do not have the knowledge often, and sometimes they're told not to share a whole lot of information for a variety of reasons, including technicalities as well as who owns them. And we'll talk more about that in a minute. And then lastly, even the most ardent followers of the system probably cannot uncompact the complexity and opaqueness. For example, I've followed this my whole life, and I've been stung by surprise bills because I didn't understand what a certain facility was, or I just didn't have the time to dig into it given a busy life. And that's sort of what happens to Americans every day. So when you're getting that test or procedure or surgery, you might arrive at a given place of service or location and not really know what you're potentially up against. You could arrive at a physician's office for a procedure or a test, and you may find out later that that physician was owned by a hospital and you weren't aware of that. And there's a facility fee or a higher fee attached to what you got performed. When you go to a freestanding facility, you don't know if it's owned by a hospital or a freestanding entity, and therefore what that cost might be. You don't know when that facility was either converted to a hospital owned or built by a hospital, which has implications. And we'll talk more about that, about whether you receive a facility fee or high rates. If you do potentially go to place of service 22, outpatient hospital on campus, you probably are a little more aware of what you might be in for, but you don't know the difference between what that cost would have been and what you're going to pay. You might know that you're in for a higher cost, but beyond that, you don't quite know what the difference is. So this is all very concerning out there. And so people every day are going in blind for these procedures, tests, and surgeries and aren't quite sure what's going to happen. As a side note, I would note that there's a major trend right now where people are going in for preventative services under the Affordable Care Act. Let's say a mammogram or a colonoscopy. They expect it to be zero. And depending on the facility you go to, you're getting a facility fee bill in the mail. And some health plans are saying, well, your preventative service is free and we're covering that, but we're not covering a facility fee. So that's a big issue. I would also note that oftentimes patients really do not have a choice of where to obtain a service. So unless you're a really savvy consumer, again, doctors tend to dictate where you should go for a service. They may say, you should go here, and you just blindly follow the doctor. Or the doctor gives you a couple of choices, but the location that he wants to practice at, a hospital-owned one as an example, a higher cost one, you may actually unknowingly say, well, that looks like the most convenient because of when the doctor is going to go perform the procedure or the test there. So that's a major issue as well. So we're not only blind, but increasingly we're being dictated as patients where to go for procedures. And the reason that is occurring is today more than 50% of doctors are owned by hospitals or health systems. Every year, more and more doctors are being gobbled up by hospitals and health systems. There's a lot that goes into this. There's physician burnout. There's costs of running a practice and things like that. But there's also the greedy nature of hospitals and health systems who want to acquire physicians, not so much because they want to deal with primary care and some of the specialty care, but they want to shift practice patterns where shift it from low-cost settings to the hospital-owned facilities, inpatient hospitals sometimes, but more importantly, outpatient on campus, place of service 22, and freestanding hospital-owned off-campus, place of service 19, and other diagnostic facilities and things like that. So when a hospital acquires a physician group, sometimes they acquire a facility that these hospitals may have owned. It could be a diagnostic center. It could be a formerly place of service 24 ambulatory surgery center. And what they do is they rebrand them to a hospital off-campus place of service 19 as an example. and higher prices sometimes can accrue to the hospital for that. In a minute, I'm going to tell you where some small steps in site neutrality tried to stop some of that, but we do know that that is part of what happens out there in the market, at least in the past. And so that's sort of how we're trapped into having to go to certain places, usually higher cost places of service with changing practice patterns, because our doctor is basically dictating that we go to these higher price settings because they are now owned by a hospital or a health system. And I would even note that if you go to a doctor's office, if he's owned by a hospital, you could get a facility fee for that surgery done in an office, because technically speaking, that office is part of that hospital or health system. I would note that in essence, the lack of really robust site neutral payment policies incentivizes hospitals and health systems to keep acquiring physicians so as to keep diverting services to higher cost settings by changing physician practice patterns. So it really does stand to reason that patients and health plans should be billed the same amount for a given service, regardless of where it is furnished, any of those places of service. It's fair, it's equitable, and it would save the system a great deal of money and patients tens of billions of dollars. Before we take our first break here, I wanted to talk a little bit about what I call the double whammy for patients in terms of out-of-pocket costs if you end up at one of these more expensive places of service because of lack of site-neutral payments. So obviously the system is impacted because tens of billions are being paid in excess charges to these hospital or health system affiliated places of service. And those prices can be dramatically different. But the patient actually pays more in two ways. First, he or she in general may pay more because the cost sharing is based on the higher fee or plan approved payment. More important, though, to save money and keep premiums lower, health plans have had to design benefits that differentiate basis on places of service. And so hospital outpatient or a hospital-aligned service facility may be subject to a different type of cost sharing. And it would be higher by nature, not even accounting for the higher fee. As an example, a hospital-aligned service may be subject to a deductible for a given place of service, as well as coinsurance as opposed to a fixed copay. So that's sort of the double whammy, a higher cost in the fee in and of itself, and then a different structure of your cost sharing and your benefit could impact you because of the lack of site-neutral payments out there. With that, we'll take our first break, and we'll come back to go into the history of site-neutral policies.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back. We hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about site-neutral payments and all of the confusion and added costs that this is in our system. So I said right after the first break, we would get into some history of site-neutral policies here. And so, as I alluded to at the beginning, site-neutral payment policies to some degree are in law, but we're a little bit in limbo. We haven't gone to the next step. So now I want to talk about what Congress and the federal government has done in terms of going down the road of some site neutral policies, but they're sort of rather slow, and we're sort of waiting for the next major step here. So again, as we know, hospitals can have on-campus outpatient departments, place of service 22, attached to the hospital campus, as well as off-campus outpatient hospital departments, place of service 19, and those rates are much higher than other places of service. Well, because of the trend that I talked about earlier of hospitals and health systems converting previously freestanding provider-owned assets to hospital-owned assets as they acquired physicians, there was a small step in dealing with that issue because it was driving up costs considerably. So in 2015, the Bipartisan Budget Act, the BBA, moved to Medicare site-neutral payments for any new off-campus hospital outpatient departments. So we're dealing with off-campus place of service 19 here. You know, a hospital converted when they bought the physician group and other assets from a 24 to a 19 or an 11 to a 19 or something like that. And Medicare said, wait, that's adding too many dollars. We previously paid much lower there. We're not going to just allow hospitals to do this. So the BBA limited new hospital outpatient payments, these place of service 19s, to comparable ones at other locations. This sort of hit the hospitals a bit hard. It sort of threw a problem in terms of their acquisition strategy. And in 2016, the hospital lobby flexed their muscle, and Congress passed some exceptions to the new rule for certain hospitals. For example, hospital building plans that were in flight, whether they were acquisitions or freestanding off-campus hospitals, they were given some exceptions. So for a period of time, some of those, even that happened after the BBA in 2015, were allowed to get higher rates. But in a general sense, except for those exceptions, since that time, conversions or new off-campus hospital outpatient departments are actually limited to the lower rates at other places of service. So that's pretty good. The problem, though, is there are plenty of instances where there are off-hospital campus places of service 19 that are still paid exorbitantly high rates just because they're owned by a hospital entity. With those modest reforms in 2015 and 2016, next we come to 2019, and CMS expanded site-neutral payments to include clinic visits occurring at all off-campus hospital outpatient departments. So if you're getting primary care or some specialty visits at these clinic visits at these off-campus hospital outpatient places of service 19, those services were now limited to the lower costs out there. Note that I'm talking about off-campus place of service 2019 because I'm going to get back to this in a minute. So in summary, we stopped some of the bleeding by having all these conversions and building of off-campus facilities by hospitals to capture much higher payments, which was driving costs. And these were really for higher cost services generally. And then CMS also limited clinic visits at these places of service 19 to the lower costs as well. So in general, modest reforms. The hospitals hated it because it's the camel's nose under the tent. But nonetheless, they were passed, and hospitals didn't have huge impacts. And I'll tell you why that's the case in a minute. We really have to jump to 2023 in December, and I referred to this at the beginning of the podcast, for any other substantial moves in site-neutral payments. And again, it did not pass. The House passed the first proposed site-neutral reforms in some time. It proposed that Medicare Part B payments for drug administration at off-campus hospital outpatient departments match other settings. Again, rather modest. This is place of service 2019, place of service 19 only, not place of service 22 on campus. But the hospital lobby defeated it in the Senate. They didn't have it move anywhere. And what that bill would have done is require these off-campus hospital place of service 19s obtain and bill under a separate national provider ID to limit their cost to lower. So that did not happen. As I said, the hospital lobby stopped it. But there is some feeling that a bipartisan consensus in each house is growing that something like that should be done. Why is this important? Well, it's important because Medicare Part B medical drug costs are increasing dramatically. And part of it is related to the higher costs at hospitals. Again, this was a modest move for place of service 19, but it would have been a good step in the right direction to limit those huge costs that occur for medical drugs like chemotherapy, but also the huge out-of-pocket costs that patients are getting as well. So let's talk a little bit about what are the current costs without site-neutral payments and what are the potential Medicare savings. And so there's a broad range of things that could occur here, and we're going to sort of walk through that. Now, let me tell you first that the savings can be enormous because of the fact that most of the services owned by hospitals are still done on-campus place of service 22 or the like versus these place of service 19s. So as one example, the on-campus hospital outpatient departments account for 87% of Medicare spending on hospital outpatient services in 2022. On-campus hospital departments account for 2/3 of clinic visits at hospital outpatient. So again, while I like these reforms about place of service 19 that have been passed as an example that we just talked about, the savings are somewhat minimal because most of what's occurring is on campus at hospitals. And I would note that as these limitations occur on off-campus rates, practice patterns are changing even more. Physicians owned by hospitals and health systems tell their employees to remain on campus, and people do that and are paying much more out of pocket to do that because of those further changes being done. So thus, the bulk of savings from site neutrality would come from applying it to on-campus, for example, place of service 22 as well. So let's talk about the fact that ambulatory surgery centers, freestanding diagnostics and labs, and physician offices not owned by hospitals have reimbursement that is well below what on-campus and off-campus hospital outpatient departments receive. Various studies analyze the magnitude of the difference, and of course, there's different numbers out there, but directionally, they all say the same thing about the difference between what hospitals receive for services done at lower cost places of service. So let's look at a couple examples here. So Medicare rates for ambulatory surgery centers are 50% of hospital outpatient rates. Payments for initial preventive exams were 51% higher in 23 when provided in a hospital outpatient department than in a freestanding physician office. One study found Medicare Part B pays hospitals almost double what they would pay a freestanding physician's office for the same service, although reimbursement rates can vary. Another study found that average reimbursement for drug administration services was 129 to 211% higher in hospital outpatient departments than in freestanding physician offices in 21. For surgical specialties, Medicare reimbursement was 224% higher for hospitals. Some studies suggest that certain services are reimbursed for hospital outpatient 5 times higher than other services. So that's just hugely significant. We have anything from 51% higher, for example, to as much as 5 times higher. It's just absolutely amazing and shows the need for site-neutral payments. So how much Medicare savings could be obtained? Again, there are various studies and there are various numbers out there, and depending on the scenario, site-neutral payment adoption would save between $5 billion at the very, very low end to $145 billion over 10 years. So let's break it down a little bit. So the December House of Representatives provision on off-campus hospital outpatient department drug administration would have saved $3.7 billion over 10 years. Others say it could be as much as $5 billion over 10 years. So it's a modest reform, but it would save up to $5 billion over 10 years. The new off-campus hospital outpatient department equalization noted above, passed in 2015 and modified in 2016, saves about $9 billion over 10 years. Equalizing payments for certain hospital outpatient payments on and off campus for drug administration, similar to the House but significantly expanded to include off campus and on campus, would save Medicare Part B $6 billion in 21 and beneficiary cost sharing by $1.5 billion. All services most commonly provided in less expensive settings, as identified by MedPAC, are estimated to save $18 billion over 10 years if applied to off-campus hospital outpatient departments. Doing all of MedPAC's identified services would save $28 billion over 10 years if applied to off-campus hospital outpatients. Equalizing all services payments in off-campus hospital outpatient departments would save $39 billion over 10 years. And most importantly, equalizing all service payments for on-campus would save an additional $102 billion over 10 years. So in sum, MedPAC actually has a number very close to this. It estimates on and off-campus equalization, so basically place of service 22 and place of service 19 with all other lower cost places of service, that equalization would save $145 billion over 10 years for certain services, $18 billion off campus and $127 billion on campus. So that was a lot of numbers, but in essence, it shows you that if you get very, very aggressive and equalize all payments for place of service 22 and 19 with all the other places of services, lower rates and costs, you could save up to $145 billion over 10 years in doing so. And that is significant to the system. And I would note that there's also the savings for out-of-pocket costs for members as well. So with that, we are going to take our next break, and we'll come back and talk about how commercial ties into this and bring in some of the arguments of the hospitals and sort of tell you why I think most of them are not legitimate.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this edition of the Healthcare Labyrinth Podcast on site-neutral payments. We've sort of gone through the bulk of our podcast here, and we're going to sort of just end with sort of bringing it together again and talking about a little bit on commercial here and why that is very important in the equation too. We spent a lot of our time talking about Medicare. Well, the reason we did that is because of the link between Medicare payments and hospital payments. So, what is the status in the commercial world of site neutrality? And what is it doing, the commercial world, on site neutral payments? Well, private insurers typically aim to have site neutral payment policies. But the reality is that unless and until Medicare migrates there fully, or at least substantially, commercial efforts to move to site neutral policies will really mean poor results and continuing high costs within the commercial world. This is because many commercial rates are based on Medicare rates, and hospitals fight for as much reimbursement as possible in the commercial world. So given that tie to Medicare rates, the lack of site-neutral policies mean commercial rates are also arbitrarily high, like in Medicare. A Blue Cross and Blue Shield Association study found the following. And I want to note that this is sort of greater than that estimate of Medicare savings that I talked about earlier, up to $145 billion just in Medicare. We're talking now about the higher cost in commercial alone. So that Blue Cross and Blue Shield Association study found a couple of things. One, average prices paid for a large commercial population were 31% higher for clinic visits in 22 when provided in a hospital outpatient department setting compared with a freestanding physician office. Average prices paid for a large commercial population were 238% higher for chest x-rays in 2022 when provided in a hospital outpatient department setting compared with a freestanding physician office. Average prices paid for a large commercial population were 563% higher for prostate biopsies in 2022 when provided in a hospital outpatient department setting compared with a freestanding physician office. So a lot like what we talked about higher prices in Medicare as well. The Blue Cross and Blue Shield Association sort of brought it all together with an estimate of what a full implementation of site neutrality across all places of service would save both the Medicare system and the commercial world. It said that $471 billion would be saved over 10 years, roughly 2024 to 2033, if site neutrality was comprehensively put in place. So that $471 billion over 10 years is for the savings to the government, Medicare, the savings in the commercial world because costs would go down and private premiums would go down, and then the Medicare patients' out-of-pocket costs. And so earlier we talked about a MedPAC analysis that said about $145 billion, let's round it to $150 billion, would be saved with comprehensive migration in the Medicare world. What this is showing is that double that amount, more than double that amount, about $320 billion over 10 years, would be saved in the commercial world. So we're talking almost $500 billion, almost $500 billion over 10 years, roughly $50 billion annually in current dollars could be saved by migrating to site-neutral payments for Medicare and commercial. The University of Minnesota economist Steve Parente estimates that about $847 billion could be saved by employer health plans from 2024 to 2033 if hospital-owned medical practices as routine office visits, labs, and more were paid at site-neutral rates. So that's an even bigger number to think about as well. What do hospitals say about all this? Well, hospitals, of course, cry Armageddon if site-neutral payments are mentioned. Hospitals argue the following to stop site-neutral payments in favor of higher payments. They say they are subject to expansive regulations that drive costs. Most hospitals are required to have expensive 24/7 by 365 emergency departments and related services. The above means huge capital and financial overhead commitments and risks. Hospitals say they serve individuals with greater healthcare risks, complications, and comorbidities. thus service costs far more to provide. I would note that other studies show that such differences are fairly minimal, so I'm not sure I buy that higher risk argument. Hospitals, they say, receive just 82 cents of every dollar in costs of caring for Medicare patients. In 22, Medicare underpayments were about $100 billion, according to the hospitals. I tend to also doubt that because I think many of those estimates are really based on inflated costs and inflated operations. And hospitals also say that site-neutral payments would mean cost cutting, leading to decreased access to care and poorer quality. Thus, they argue that it will simply mean greater under-reimbursement. Well, again, as I told you, I'm a former hospital board member of 2 hospitals. I am not unsympathetic to the unique position of hospitals, as well as the many challenges and regulatory and other pressures they have. But it's hard to get past a few fundamental points on this issue. Many hospitals, especially with consolidation, have poor and diminished quality. Quality and safety at other places of services are as good or better and less risky for patients than at hospitals. The overcharging by hospitals is hard to justify and drives costs in both the Medicare and commercial world, and especially for Medicare outpatient costs, and many of these folks are on fixed incomes. The current payment structure dissuades hospitals from reforming and becoming much more efficient. They just glom on and spend lobbying money to preserve the payment rates that they get. The current system also is very anti-price transparency, and as I've argued, price transparency is absolutely key. The excess charges at off-campus hospital departments are especially hard to justify in my mind because this is a relatively new phenomenon in healthcare. I think it amounts to an abuse of billing. Site-neutral payments could also be structured to protect critical access in rural hospitals. This is another charge that the hospital lobby makes about why site-neutral payments should not happen across the board. You can create other government payment schemes or funding that could protect some of these most important unique hospital assets around the country without giving overpayments to every hospital. The hospitals charge that Medicare is a major under-reimbursement, as I pointed out, is very speculative at best. Hospitals have a hard time truly understanding their costs. They engage in all sorts of financial gymnastics to arrive at the underpayment figure. They, again, as I noted, are also based on bloated costs and investments. So I don't trust those numbers at all coming out of hospitals. I think the most important point I would make here about the need for site-neutral payments in conclusion is hospitals' track record does not really show them to truly care for everyday Americans. Many of them charge these excess fees without letting patients know, and then they sue these same patients to garner wages and more when Americans cannot pay the exorbitant freight. That sort of tells me that site-neutral payments alone would give relief to patients that hospitals are unwilling to give themselves. With that, we'll conclude this podcast, and we'll see you on the next Healthcare Labyrinth podcast. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.